25 plus people.
So I think we can start. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Dr.Nauman, and we have a wonderful collection of people here, and more are joining. This webinar is important in a sense that we have been working on peritoneal dialysis for quite some time, and we have achieved to a certain level of peritoneal dialysis CAPD. And the only gap that was there was the automated peritoneal dialysis, or APD, in our patients. And luckily, with the help of Byonyks and the support of the nephrologist community, we have been able to join APD in the armamentarium of our peritoneal dialysis therapy. And it has been a good experience, a learning experience for many of us in Pakistan, looking at the needs of our patients. And we would like to continue to improve in the provision of these therapies to our patients who are requiring intervention in terms of the renal replacement therapy. So I welcome Dr. Irfan Munir. He is a consultant nephrologist and a senior nephrologist in Indiana, USA. He'll be, thank you very much for joining. Then we have Dr. Ahad, who is the president of the Pakistan Academy of Pakistan, Peritoneal Dialysis Academy of Pakistan. And we have Dr.Nauman. He's a consultant and assistant professor at MAYO Hospital. And we have Dr. Faiza, who is filling in for Professor Dr. Shafiq Chima. She's a consultant nephrologist at Jinnah Hospital, Lahore. And myself, I am Dr. Nauman Tarif, and I'm a consultant nephrologist in Lahore and associated with Byonyks, provision of APD. So I think what we'll do is we'll have a discussion about a few presentations, brief presentations, and most of it will be a discussion that will be followed up with the help of Dr. Irfan Munir and our worthy speakers. So we can start with Dr. Ahad with his presentation. Dr. Ahad, please.
Right. So thank you so much. I'll just start screen sharing. Let me know if you can see my screen. So it says that the host has disabled screen participation. Can you sort of, Nauman sir, whoever is yes, host, can you make me co-host or allow me to sheet screen?
1 second. You can try now. Okay,
yeah.
Good.
Can you see my screen?
Yes.
Okay.
Yeah, we can.
Okay, excellent. Just let me make it like so. Okay, here we go. Right. So considering that we're talking about, I've already been graciously introduced. So thank you so much for Nauman Saab and the organizers for inviting me to be a part of this wonderful program. Considering we're talking about automated peritoneal dialysis, I'm just going to talk about a few of my patients, rather one patient who was sort of delegated to me to talk about that, why we put him on automated peritoneal dialysis and how he fits in the low resource setting. So, of course, in the interest of privacy, I will not be exposing his name. So he's a 42-year-old gentleman, quite a dear patient of mine, who was diagnosed incidentally to have CKD when he was applying for a visa to the UAE. And that was the first time he found out that he had an increase in serum creatinine and he was on hypertensive. And this was back in 1998. And lo and behold, within 1 year, he was on dialysis. I had to start hemo, as we did back in the day, that, everybody who ended up on dialysis, we just put them on hemodialysis. So in 1999, he started his hemodialysis. His mother wanted to donate a kidney. In 2000, he had a live-related kidney, and that kidney worked for 14 years. And, and it just sort of felt, I haven't seen the biopsy myself, but I was told that it was chronic rejection and chronic allograft nephropathy. And he was back onto dialysis after 14 years with a transplantation. He did hemodialysis for 1 year. And unfortunately, after 1 year, he, during a screening, of the usual screening that we do in our center, we found out that he was HIV positive. So that with the stigma, even now, and let alone 10 to 20 years ago, that would have come as a major blow to the patient. And at that time, everybody sort of, any in-center refused that, no, you have HIV positive, we cannot accommodate you in hemodialysis, which is quite a shame, because we know the guidelines how to take care of HIV in hemodialysis centers as well. But then again, that was that. And so as a result, he shifted in 2015 to home hemo. And a technician used to come to his house, and he had to do it out of pocket per session. 5,000, 7,000 rupees in 2015 was probably 18,000 rupees nowadays, considering what the economy was like in 2015. And he had to pay out of pocket, and was he doing home hemo at that time. So secondly, for 1 year, for about 6 months, he was doing okay at home, but then he started complaining that, I have multiple issues. He kept on dropping his blood pressures, visited his nephrologist at that time, got his dry weight adjusted, but he wasn't doing too well. He just kept on having those intradialytic hypotensive episodes, those cramps, and he was, sick and tired of doing home hemo. On the 16th of December in 2021, he reached out to us through Professor Nauman Tarif, and he was started on CAPD initially, and that was how the training started, and he was put on PD at that time. In February of earlier this year, we got him in touch with, we got hold of a cycler and recruited him, and he started his automated peritoneal dialysis from the 25th of February 2023, and he's been doing it independently since then. Alhamdulillah, he's been doing quite well. His APD prescription is 4 cycles. We do a fill volume of 1300 ml, 90 minutes 12 times with the last fill of 1300 ml. The last PET we did on him, we found out that he had a D by P ratio of 0.6, which makes him, a low to low average transporter. And he's dialyzing pretty well with the creatinine clearances of KT over V of 1.91 per week, which is quite acceptable as far as peritoneal dialysis is concerned. He does do APD majority of the time and 7 days a week. When he has a little bit of burnout or is just tired of it, he moves back onto CAPD. So he makes a hybrid, but more often than not, he would do APD cycles. And he's very, very happy that, he doesn't have any, clinical complications. He doesn't have any nausea, vomiting, or any shortness of breath. Diet is quite good. He takes his, heart therapy, efavirenz, lamivudine, tenofovir, and is on the standard regimen which any dialysis patient would be. And since February, I haven't had any problems with him, and he hasn't suffered any problems there and then either. He does not need I think I missed one slide, but nevertheless, I just wanted to share the labs as well. His hemoglobin is fine. PTH is doing well as well. Serum albumin around 3.4. So all the markers that we want to see in a hemodialysis or a peritoneal dialysis patient, he's doing really well. And he's doing pretty well on peritoneal dialysis. So just want to talk about that. He's pretty happy with what APD is doing for him. He doesn't need a caregiver. He's a pretty independent guy. Has a following on social media as well, has a YouTube channel of his own, does online businesses, and he's a very, very active guy. So he sort of thinks that this is what he wanted from life. Of course, he wouldn't want to be on dialysis in the first place, but the second best option is probably this, and he's doing pretty well. One thing that I would like to highlight is, and I had this discussion recently with the ISPD guys as well, and they will sort of think that APD is only and only for patients who are high transporters. I would beg to differ, considering this patient as an example, considering his intradialytic hypotension, and a place like in Pakistan where HIV is a problem and no center would probably entertain him adequately. So yes, apart from a high transport center, APD is for such patients as well, even if it's in a low resource setting. So that was that. If I have any questions, or I can take that question at the end of your presentation as well.
We'll have thank you very much, Ahad. We'll have the questions and answers and discussion at the end. And now I'd like to ask Dr. Nauman to share his patient.
Can everyone see my screen?
It's not yet. आपकी presentation अभी नहीं आ रही आगे.
My patient QA, a 52-year-old male, a known case of CKD since June 2022 due to diabetic kidney disease. He also has comorbidities of hypertension and ischemic heart disease with low ejection fraction. Due to poor follow-up, he presented to us in November 2022 with CKD5 requiring dialysis. So he was put on maintenance hemodialysis via temporary catheter and remained on hemodialysis for about 3 months. Keeping in view his ischemic heart disease with low ejection fraction and recurrent episodes of hemodynamic instability during hemodialysis, he was consulted regarding the benefits of peritoneal dialysis and other benefits like he will become autonomous at home after a while after getting proper training. So he gave us consent in February 2023. So his PD catheter was inserted. His son was trained for CAPD and APD at MAYO Hospital, Lahore by our PD nurse. And APD was started on 21st of February 2023. He remained at MAYO Hospital under supervision of our PD nurse for about 3 months till 15th May 2023 when he became independent after giving a proper test. And he is continuing his APD till now. His current APD prescription includes APD 5 days a week. Each day he does 3 cycles with fill volume of 1500 ml of 1.5% of devote PD solution and dwell time of 90 minutes. His current urine output is 100 ml per day. He is clinically well without any signs of overload or uremia or under dialysis. His son works at call center 9 a.m. to 6 p.m. After coming back from job, he starts APD at 9 p.m., which gets complete around 9 a.m. And after that, he goes to his job. Being on APD, it was win-win situation for the patient and his family, as he does not have to go to hospital for hemodialysis. And APD is the best option because of his cardiac issues, keeping in view his hemodynamic instability during hemodialysis. His son can work and take care of the family and his father. So patient and his whole family is happy and comfortable. Just one thing I would like to add regarding this patient, that initially when he was put on APD, he developed moderate degree of pericardial effusion around about 350 ml fluid. So APD, we did his intensive dose, and about after 2 weeks of intensive automated peritoneal dialysis, his repeat echocardiography showed that whole of his pericardial effusion had settled. But later on, since then, over for about around about 8 months, he is doing totally fine on his APD. Thank you. Any questions?
Thank you very much, Dr. Nauman. We'll have the questions at the end. Now I'll ask Dr. Faiza to share her presentations, please.
Yes, sir.
Please.
So can you see my slides?
Yes, please.
Okay. So now today I am sharing a success story of APD. The patient I have, he is a 38 year.
Just put it on the slideshow mode.
So it is not on slide. You cannot see the slides.
We can see the slides, but you can put the presentation mode.
Oh, okay.
There you go.
Yeah. Okay. So he is 38 years, married male, having 2 sons and 2 daughters. He was diagnosed as having aplastic anemia in 2015, underwent bone marrow transplantation in 2016, and then he developed, after bone marrow transplantation, CKD. He was initiated on maintenance hemodialysis in 2018. Thing to note was he lost his job in 2015 when he was diagnosed as having aplastic anemia. Then he underwent treatment for aplastic anemia, and after that, he was on maintenance hemodialysis, was coming to dialysis center thrice a week, so it was not convenient for him to continue his job. When on hemodialysis, he was having problem with the excess. He was having excess failure. 2 fistulas failed on one on left arm, other on right arm. We inserted permanent lines, but it was not working for him. He was having repeatedly blockade of the lines, and 4 permanent line was failed. So we planned to shift him to the peritoneal dialysis. We started CAPD in November 2022 at Jinnah Hospital, Lahore. At that time, we advised him 4 exchanges with 2-liter 12 volume, one of 1.5% solution, and he was undergoing that. He was perfectly fine with that. He was having urine output of around 500 to 700 ml per day at the time. Then we discussed with the patient, and he was happy to get shifted to APD. In April 2023, we started his APD at Jinnah Hospital, Lahore. Initially, we started in-center APD. He used to come in the morning, underwent APD for 8 hours in our center where he got trained. He and his brother got trained for APD. He got training of 3 weeks. Then we shifted the machine to his home, and he was shifted to home APD independently, and it is continuing till date. He was very depressed at the time the hemodialysis and PD was initiated, as he was jobless, he was dependent, the family was supporting him. In May 2023, when he started APD, he was feeling a bit independent, and he started a job as a data entry clerk. That was 9 a.m. to 6 p.m. job in a garment factory where his wife was already working as a tailor. His prescription is 4 cycles with 2-liter dual volume for 2 hours with 1.5% of the bags, and he do APD from 7 days a week from 9 to 10 a.m. till 7 a.m. morning. He's clinically fine, having no uremic features, no weakness, and his intake is good. He's doing, as I told you, 9 to 6 job. So when he comes back from job, he eats, drinks, spends some time with family. Then he starts his APD around 9 to 10 p.m. and it continues till 9 a.m. in the morning. Then he disconnects from the machine and carries his normal activity. Now he's happy, he's more active, he's energetic. He feels himself more confident and productive after starting APD, especially after now he got a job. So for this patient, the benefits of APD was he started his job, he's more active, he's more happy as he's independent, he's doing dialysis at home, no need to go for dialysis in centers. So he's feeling independent. That's it.
Thank you very much, Dr. Faiza. That was a wonderful story of a patient being independent. And now I'm going to just share my patient. Let me just put this on first. Okay. I have to go back. Sorry. Okay. So this is, you can hear me, right? I can't see my. This is an 18-year, at the age of 18 years, in 1996, this patient was a freshman in engineering university, and he had accidental gunshot injury at C4-5 level while he was standing, and he was not part of any political activity there, and suffered this unfortunate injury. developed quadriplegia, hospitalized for 6 weeks, and then he has remained bedbound and totally dependent on family support since then, since 1996. Due to atonic bladder, and he was shifted to continuous intermittent catheterization and then suprapubic catheterization in September 2022. His CKD started because of recurrent infections in 2020, and this year, about in January, he reached to a stage of CKD5. He has been bedbound since September 1996, and it has been very challenging for him to go to the clinics even. And whenever he visited in my clinic, I used to feel very sorry for him and for the family, and the care and the love that they have provided him since 1996. So challenging was the hemodialysis. So we said, okay, if it is possible to go for peritoneal dialysis, since he has a suprapubic catheter, so we looked at the literature. So there were chances of some increased exit site or peritonitis, but anyhow, it is a possible thing. So even the ostomies and all these issues with the drainage on the abdominal wall, the PD is quite possible if you have the peritoneal cavity available. So PD catheter was inserted in May 2023, this year. And his father and his brother were trained for CAPD, and then he was trained for APD. So now he has been on APD since June 2023, independently done by the family. So his brother starts APD at 9 a.m. because he has to go for his job. And when he returns in the afternoon, somewhere around 7, 8 p.m., then he disconnects the APD therapy, and it's completed. And his father takes care of his other issues. So as the patient is bedbound, and so APD was probably the best option because of all these issues that I've just mentioned. He has a residual renal function of about 1200 ml per day, and he's on APD 3 times per week with a good KTOV that he has achieved somewhere around close to 1.1 or so. His brother does not have to spare the whole day for his dialysis. He can go to his work. The patient is clinically fine. He does not have any uremic symptoms at this time. Previously, he had some symptoms of GI upset, some constipation because of his chronic condition, but that was taken care of. And he himself is a little bit independent in terms of he can move his arm, and he can eat with a little bit of a support from his right hand. And other than that, he's quite dependent. But luckily, alhamdulillah, his family has been taking care of him. He does not have any bed sores. He can manage eating with his own hand and some support. Mentally, he is very alert and good IQ. And he understands his disease and needs. And he himself tells us, what was the intake, output, and all these things. And his family and patient himself are very much satisfied and comfortable currently. So I think with this, I'll just stop sharing my slide. And okay. So with these presentations, the commonality is that these patients have some certain needs and issues, and for them, automated peritoneal dialysis has made some difference in their lives. And from this, I'll just take it to Dr. Irfan Munir for his comments. He has been taking care of PD, large population of PD patients, and he can share his experience abroad. And he has been very active in MAYO Hospital, Kemkana. And with his support, the PD program is going on quite well. And he can, from both sides of the continents, from Pakistan and from USA, he can share his experience. Thank you very much.
Thanks, Dr. Nauman, for a candid introduction and excellent presentations. And the more we hear about these kind of discussions and stories, the more we become believers of peritoneal dialysis. So within the nephrology, I have not prepared slide, but I'll start by a short presentation of a patient I saw about 8 weeks ago, 59-year-old male, diabetic, nephrotic, presented to the hospital with uremia and volume overload. And he was very forgetful, but apart from his dementia, he appeared to be very reasonable candidate for peritoneal dialysis. His wife worked full-time, was a breadwinner of the family. And I discussed the case with the wife, and she said she was going to do dialysis, and with her work routine, they can do the cycler-assisted dialysis. And that is something which is going to fit in her schedule nicely. So on the Friday, I signed off. I was not on call on the weekend. And I come back on Monday, I suddenly see that patient has been converted to hemodialysis by my partner. So on presentation, the fellow was frankly uremic. And on Monday morning, they were getting set up to remove his PD catheter. So I stopped that. We kept him on hemo for during the stay in the hospital. Gradually, his mental status improved, and then he got transferred to a rehab for 2 weeks. And then once he recovered in rehab, he went home, and we trained his wife. He started peritoneal dialysis, and if you can enlarge, here is picture this last week. I saw him in the office, and that is the way he looks. So initiating patients on peritoneal dialysis, the battles which you have to win, not just convincing the nephrology patients that it's going to be a good modality of dialysis, but it's also in the nephrology community. I mean, we have to convince our peers and colleagues that this treatment really does work, and that is the way to move forward. So just I'm going to touch on the cases we've just discussed, and with a brief historical perspective, which most of the nephrologists are very well aware of. The reality in the United States was that around 2000, the penetrance of peritoneal dialysis in all the end-stage kidney disease was about 4%. So 4% patients back in 2000 were being dialyzed with peritoneal dialysis. Majority of them were being dialyzed by hemodialysis. The initial push towards doing more and more peritoneal dialysis came across because of seeing the economic benefit and the impact the expense has over the total cost of healthcare system. And then subsequently, some articles started popping up in the literature talking about some early survival advantage, some better preservation of kidney function. So there's been more and more push towards by the CMS and the intermediaries and the insurance companies to encourage doctors to do more and more peritoneal dialysis. And where we are focusing now is we are trying to educate our patient earlier on in their course of chronic kidney disease, so they're well aware of different modalities of treatment which they will have if ever their kidneys will fail. I mean, that is one thing. Providing early education is something which will help us to convince and increase the utility of peritoneal dialysis for treating end-stage kidney disease. Now the other area where we are focusing is, like as Dr. Ahad's case, that the conversion of patients who are not tolerating their hemodialysis to peritoneal dialysis. So when you see across in the hemodialysis units, you'll see a lot of patients which you're taking care of are complaining of cramping, feeling washed out after hemodialysis treatment, or not just feeling good, and getting these hypotensive episodes. And those are the ideal patient. When you start talking to them, they would be certainly more inclined to consider an alternative treatment where all these symptoms would not be there and compromise their treatment and decrease the subjective sense of well-being. The other thing which Dr. Ahad pointed out in his case was that in low transporter, doing APD in low transporters. Well, I think we should use APD in almost every patient, whether it's a low transporter or whether it's a high transporter. It's just one-time cost. I mean, it does not change the total cost of treatment over years. Actually, it will decrease it. And then I'll encourage you to all come and attend our symposium and coming December, where we're doing a symposium on home dialysis. But a low transporter, the way I use it, I use 3 cycles at night. Then most of the time, if they have reasonable urine output, typically I don't do anything during the day. Once they start losing their urine output, we can add one more exchange during the day, and they do pretty good with that. And what it adds, using a cycler when a low transporter patient, what it adds the quality of life. Nobody wants to do 4 exchanges in a day. If you cut the 4 exchanges to 1 connection and disconnection during the day, that's a huge benefit in terms of quality of life. The second thing, in Pakistan's environment, it is decreasing the number of touches which you're making while making the connections, which will certainly decrease the chances of getting infection, getting peritonitis. So I think it was an excellent idea, Dr. Ahad, using APD in a low cycler. And I only do APD in a low or low average cycle transporters. I do not do any CAPD even in low transporters. So that is my standard practice. Patients love it. I love it. Never have any issues with the clearance and subjective well-being of the patients. So the next patient was, I think, Dr. Nauman discussed. I think we had that patient in common, and when I talk about the success of our peritoneal dialysis program at Mayo Hospital, I'll express words kudos to both Dr. Nauman Bhatt as well as Dr. Nauman Tarif, because they have both done a phenomenal work. And when I talk with my peers in the United States, and I tell them that our retention rate was 100%, we had 0 dropout. That is phenomenal. I mean, we don't see that example even in the United States. Typically, in the general practices in USA, the retention rate of PD patient is about 50%. So I'm not talking about like 3 months out. We're talking about 1 year out. Our retention rate in the PD program with Dr. Nauman Bhatt is overseeing and conducting is 100%. This is great. So when we started this patient, which you expressed, and thank you, Dr. Nauman, for doing all that, as well as Dr. Nauman Tarif for overseeing it and providing all the support. So getting back to the patient, when we started the patient, Dr. Nauman presented, we saw him together. He was dyspneic and hypotensive that day. And he had orthostasis and with a clear chest. And then when we both thought that probably he's a tamponade, because he probably has an early tamponade, because he was quite uremic going into dialysis. And subsequently we intensified his dialysis, those symptoms resolved. And it's great that at this point he's just needing 6 liters a day of PD exchanges. I didn't see any KD/V. I don't think we really need to do KD/V. We need to move towards what Dr. Nauman Bhatt pointed out, patient-centric, quality of life-centric peritoneal dialysis. Electrolytes volume status is good. Patient is feeling well. That is all what you need to accomplish. We don't need to stick to the numbers. And when we talk about science, there's no solid data which will support that a certain degree of KD/V below which we can say that peritoneal dialysis patients would have a bad outcome. I mean, certainly it's a number. It may be somewhere around 1.2, But what that number is, we don't know. There's not been any study on it. As long as we're keeping KT over V above 1.4, 1.5, all these patients are doing well. More than that, if patient is feeling well, their volume status is good, electrolytes look good, we don't have to stick with the number. So the two learning points in what Dr. Nauman presented, three learning points which I picked was the patient-centric, goal-directed treatment, not treatment centered to optimum KT over V values. And number two, yes, when we started, when I started supporting and starting few patients in MAYO Hospital, I was very reluctant in letting them go home because my reservations was that the chances of success on PD at home will not be high, which is still true with a decent number of patients in Pakistan, but this kind of patient whose son is educated, he was able to learn peritoneal dialysis, he was able to provide treatment to his father over last year without any issues. So yes, that can be done, and that is possible. The other thing, which is third point, which I'm going to dwell on a little bit, is assisted PD. Assisted PD is something which has not grown a lot in the United States, but over next several years, I think that is something which we probably need to move towards, because once we have the infrastructure of provision of peritoneal dialysis in place in Pakistan, I think we need to start thinking about centers where we can train our staff and bring in patient and provide in-center PD. I feel the success rate is going to be high. I feel over long haul, once the infrastructure is in place, our cost is going to be significantly less, and that's going to help out like the growth of peritoneal dialysis as a modality in Pakistan. So that is a thought process which probably we'll all be discussing in future about, but that is something which came in my mind. I'm just going to throw it out there for all of you to sort of think about it and just see what we can do together moving forward on that. So that's where I'm going to stop. I'm going to give other people time to speak and express their thoughts. Appreciate
Thank you very much.
Opportunity. Thank you.
Thank you so much, Dr. Irfan. That was a wonderful discussion and experience sharing. You're absolutely right. Once you have the patient on PD, peritoneal dialysis, and they feel different than being on hemodialysis if they are switching from hemodialysis. They look quite different. They're more energetic, the lifestyle, psychologically, they improve so much that it gives them, it's a total different experience for the physicians also when we see them. Number two is the automated peritoneal dialysis. It gives them the freedom, as we have seen in our patients. 3 of them, actually, they require almost all of them. They require somehow, it was even the peritoneal dialysis exchanges or the hemodialysis were interfering with the families or the patient's job, lifestyle, and all these things. So I would like to ask Dr. Ahad to further comment, or if there is any questions, they can be shared in the chat box and then we can answer them.
Right. So excellent talks, everyone. Great job. Congratulations. So 2 points. One is more of an echo what actually Dr. Irfan Munir and Dr. Nauman Bhatt have said. I'm a great advocate that these KT over Vs, these creatinine clearances, especially for PD, I don't think they matter. What matters is what the patient feels and what the patient looks like. So as long as the patient feels well enough, I think I've had this conversation with Dr. Professor Nauman Tarif. Whenever we wanted to do a registry, you're always asking, can you share your KT over weaves? Can you do the share the PET test? And I'm like, oh, okay, so I haven't done any PET tests. I'm just looking after my patients. We didn't have bad PD cyclers back then anyway. PD cycler, has been available very recently. But then again, if the patient looks well, that has to be the goal. So I would just sort of echo what you earlier said. Assisted PD is, I think it is tailor-made for Pakistan. Strong believer in assisted PD. You see this with hemodialysis every day. They're bringing in a patient and 6 attendants are sitting in the waiting room. I do fail to understand what those 6 people in the waiting room are doing. I feel for them. I have no problems with their motivation. They are motivated people who care for the patient. That is why they showed up to the dialysis unit. But that is loss of money. They could have been working anywhere and gaining money anyway. And if you can offer them in a home service and just teach them for a couple of days and just follow up on them, just so that is safe practice of PD, I think they can contribute financially and to the well-being of those patients as well. So strong believer for assisted PD if done correctly, because that is the main crux of the matter, that you have to train them first. It's not just like, is tarah karte hain, just go home and do it. It's just not like Nike, just do it. It has to be learn first, and then you make sure we have a program in place. And I think that would be that. So yes, PD cyclist definitely a place here. Over time, I think it definitely just looks more expensive, but I think it is eventually, if you look at economies of scale, it will be cheaper. Those are my thoughts. If anybody else wants to chip in, or if you have a question, I'm happy to help.
Yes, Dr. Nauman, do you have any further comments on there?
Yes, sir. Sir, actually, I will also second Dr. Irfan Munir's one point that we also have to, you can say, educate or push our own community of nephrologists basically towards PD, because I have seen that many of the nephrologists are on back foot while deciding regarding putting patient on peritoneal dialysis. Most of them are just want to put patients on hemodialysis, say that it is not not workable here in Pakistan. Patient will get infected. PD catheter insertion is quite difficult. So we have to actually educate our community that it is possible in our country. Doesn't matter what the economic status of the patient is, whether he can afford himself or not, because here at MAYO Hospital, we are doing about 5 to 6 patients on peritoneal dialysis, and all of them belong to lower middle class or lower class socioeconomic class. So I will like to tell all the nephrologists that it is possible here in Pakistan too. We just have to get dedicated towards it. Have to counsel our patients regarding the benefits of the peritoneal dialysis as compared to hemodialysis, not just in patients with hemodynamic instability or vascular access failure, but any patient who has become end stage and requires renal replacement therapy, he should be counseled regarding peritoneal dialysis. Many patients, even whenever I counsel, you can say that almost 80 to 90% of patients get inclined towards peritoneal dialysis. So I just wanted to say that nephrologists should also be
very well said.
it.
Once you counsel your patients, they do understand, what is peritoneal dialysis.
Yes.
But we have to show them the picture about the cost, the hidden cost that Dr. Irfan Munir and Dr. Ahad also mentioned. Dr. Ahad has given many talks about the economies involved in the peritoneal dialysis and hemodialysis. We have some questions and in the chat box, and Dr. Asad from Jinnah Hospital, he is very rightly suggested that we should register PD programs, as Dr. Nauman has already mentioned, that this is possible in the government setup with some support. And we know that there are so many supports being provided to our hemodialysis patients. Then why not, for our peritoneal dialysis patients, and further making these patients a useful member of the society also. And there is one question here.
There's a question about training. Dr. Nauman, can I take that, please?
Yeah, please.
So yes, that's which I've been thinking about for last 1 to 2 years. We are thinking about putting together a curriculum of home dialysis, mini home dialysis fellowship, which we will launch over next 6 months, and we'll try to integrate with our PD dialysis, peritoneal dialysis locations in Lahore, and the sites would obviously be. I still have to discuss those, and sites would be certainly one could be Mayo Hospital, and the other sites are definitely places where we're doing PD, where the fellows can go in and get training. So that mini peritoneal dialysis fellowship will have certification from United States, and there's more to come on it. But that's since I've been thinking about it and working on it and planning to launch it. So I just want to pitch in and just make you all aware of that.
Yes, thank you.
Assalamu alaikum. Yeah.
So,
yep.
Yes, please.
Ji, assalamu alaikum.
Ji, please.
Ji, I'm a radiologist, and I'm of the opinion that one of the bottleneck of universal adoption of PD program is ability of people to place the PD catheter safely and at not just Mayo Hospital or one place, but throughout the country, at least at the level of District General Hospital. Even if people are convinced to the utility of PD, unless if there is a bottleneck in being able to safely place the PD catheter, the program may not be adopted as much as it should. Because if it is not safely placed, one complication is going to lead to the program falling behind in that region.
Absolutely. I think you are very right.
I'm an interventional radiologist, and I can help out with at least getting the curriculum for training program.
That'll be great. I think we can join hands with Dr. Irfan Munir and we can make a part of it. Actually, we have been working on this peritoneal dialysis access. Dr.Ahad had made many workshops within Pakistan where the nephrologists have been taught how to put in the catheters. And even, we had Dr. John Crabtree, who is a well-known authority in the world in PD catheter placement in our a couple of our webinars, and he has guided our surgeons also. So it's been a wonderful experience of the last 3 or 4 years in terms of getting expertise in placing the catheter. One of the question was from Dr. Faiza about the 2 hours dwell time. I think she responded, but I think just for the sake of clarity, you can explain the dwells and the cycles.
Yes, sir, sure. We're providing 4 cycles per night from 10 p.m. at night till 7 a.m. morning. It was 2 hours dwell with 2 liters of the fluid and 1.5% of the fluid. That was we were using. So not one dwell of 2 hours, it was 4 dwells of 2 hour duration.
So it's almost like 8 liters overnight. It's like whole day. So I'll ask Dr. Puran Kumar, who has joined us from Hyderabad, he has a question there, and he's been a very active nephrologist in Hyderabad. Recently, we had under Pakistan Society of Nephrology workshop there. There were a lot of enthusiastic PGs and consultants, and I was so much happy to see all of them just having so much interest in peritoneal dialysis. And it is actually needed over there also, because that was Hyderabad is there, and then you have a large gap in between the cities, and then many cities all around it, and a lot of patients who just come in and just need dialysis, and you can't provide all those patients in-center hemodialysis. Please, Dr. Puran.
Assalamualaikum. Thank you very much, sir. Nauman sir. We also missed Dr.Ahad. He should have participated in our workshop. I think we need a lot of help for this program to be initiated in this region, because we have a lot of younger patients. Since I have seen 2 patients brought by the Dr. Salman, and they were very healthy looking. So since then, our PGs and our department realized that peritoneal dialysis is one of the best modality, and our patients who are younger one and who are willing to go for transplant, I think they must be on the peritoneal dialysis. But how can we start, and the availability of the solutions and all these things is important. So our team is very enthusiastic to participate for training. I think PD Academy of Pakistan should start all these things to give help like our people, so we can get benefit from this type of modality.
I'll ask Dr. Ahad to respond.
Right. So Puran, yes, I'm sorry, I didn't come to Hyderabad, but I did come to Hyderabad earlier. So that's fine. I just came once. Second time, I wanted to give others also to contribute and sort of take the leadership position. As far as opportunities for peritoneal dialysis to take forward, so my vision for PD Academy of Pakistan was very, very clear, to have sort of centers of excellence, and then they teach forward. I'm seeing in the chat also, for example, for Sindh. But this is just my vision and my way of looking at it. It doesn't have to be the correct way, and you may have a different option as well. So my thing was that Indus Hospital is doing excellent work with Dr. Salman Imtiaz, Dr. Javeria is there, Dr. Faiza is there, and they can be a lead resource for you, because they've got access to those people as well, and they've got loads of patients. Because for us to learn peritoneal dialysis, we need to have access to patients to see how peritoneal dialysis is being done. It's one thing to give lectures and just show that this is how you do it. So my vision was that maybe we can separate the country in various districts or areas. For example, the Sindh is taken care by Indus, or maybe you guys as well. And then you can take it forward once you think you've learned that the dark art of peritoneal dialysis. And then if we're talking about Punjab, so MAYO Hospital is doing an excellent job. Nauman Tarif is there at Fatma Jinnah. And of course, Jinnah Hospital is doing. And then again, Bahria is there as well. And we do our own PD thing as well. So fellowships are up for grabs for training purposes as well. International Society of Peritoneal Dialysis is also giving funding to go within the country. We did receive applications from quite a few. Mohsin is also here. The ISPD actually delegated a Nigerian to him, that can you teach him peritoneal dialysis? And I think he has accepted that offer. So there are lots of ways for us to sort of learn from each other. The workshops for PD Academy of Pakistan, as a sort of a rule, we sort of decided that we'll do it every 3 months. And we'll try to move it from city to city. And that will just be a stimulus for us to get a flavor of that. There was someone in the chat, Muhammad Ahmed, I know him as well. He's very much interested that we should go to Faisalabad. So I can make sort of a humble promise that next time around, we will take the workshop there as well. But for someone to learn peritoneal dialysis, I think you need at least a month, a couple of months to be associated with someone to take that thing forward, especially for PD catheter placements and do it safely. I hope I have answered that question. All right.
Great, thank you. I'll ask Dr. Javeria if she's here. She's from Indus Hospital, a very active participant in PD. She's a consultant there. Dr. Javeria, if you can unmute yourself and then. Okay, I think. Oh, there she is.
So can you all hear me?
Yes, please.
So excellent case presentation by all the participants, and actually we are looking forward to initiate APD in Karachi. And as I spoke to you earlier last week about 2 patients who are very interested in APD cycler. So And I think it can add on, it can really help them achieving a good quality of life. Like one patient who came in my clinic, and he had been contacting Byonyks for last, I think, 1.5 years for the cycler. And because he's a young guy who got end-stage renal disease due to like some concentric glomerulonephritis, and he really wants to initiate his work, his online business, but due to hemodialysis and all, he's just not able to continue with his job. So it can really add on a, a marked difference in the lives of people, and to lead a healthy life,
Excellent.
a beneficial life.
That's true, Dr. Juwaria. Thank you very much for your comments.
Society
You're absolutely
and
right. You know, we
to
have
their own life. So the,
yeah. Your voice is a little, I think, cutting.
okay. Oh,
Okay, thank you. So we have just 3 or 4 minutes left. We have one patient with assisted PD in Karachi already, which Indus team is already taken care of, and that person is so happy that he came from USA, and he feels that he's much feeling better. You know, he was unable to come to Pakistan just because being on cycler and CAPD, and he thought, you know, he would not be able to continue his PD, and will not be possible for him to manage all these things. But we have been doing this APD in Karachi, and we will be very soon reaching out to Karachi as we promised. And because of, you know, certain issues regarding fluids, which has been taken care of, alhamdulillah, in the local establishment and manufacturing, which is the goal, and just to bring down the cost, as everybody's mentioning here also. So I think these are some of the things that are real issues in our local experience in peritoneal dialysis, and that are slowly, gradually being taken care of with the help of the nephrology community, with the lead from Dr. Ahad here, and the other teams from Dr. Salman and your team and Dr. Juwaria. And we look forward for the Shafa International Hospital in Islamabad. They are very active in peritoneal dialysis. And I'll just ask Dr. Mohsen if he's around here. If there is a question here, any question? Concept question, Ajit. What is the approximate cost of the PD exchanger cycler? Well, I mean, we have tried it to bring it down to like $3,000, but it was because of all these issues with the dollar and stuff, it has gone up to like $4,500. But mind you, the international market, the machine is available at $15,000 and above, up to like $25,000. So the disruption in the APD community will be a cost-effective cycler and available for the patients. But as I said, in Pakistan, there are so many opportunities for us to support our patients from different communities, from different charities, and the patients themselves, they support other patients. So there are so many avenues, and once the government will come up into it, as they have supported the hemodialysis, so this will be available for the masses as well. So with these words, I will just like to thank everybody who has joined us here, especially Dr. Irfan Munir, Dr. Ahad, Dr. Faiza, Dr. Nauman, and all other worthy attendees here. And any last comment from Dr. Irfan Munir before we stop here?
Excellent job. Very well conducted, and thank you for doing that. Appreciate it, and looking forward to see you in December.
Inshallah. Thank you very much. Thank you all for joining and making this a success. Assalamu alaikum.